reported in the East Coast are much more significant than in the Midwest, and California also and Oregon also have a significant number of cases reported up through 2017. The major risk factors are geographical. I pointed out that the Northeast has the largest amount of Lyme cases, as well as in California and Oregon. The occupations that it usually hit are landscaping and foresters. However, anybody outdoors who can be associated with ticks can obtain this or get this infection as well. Recreational areas also have the ticks, and that's in hiking, camping, etc. The signs and symptoms you can see in any review article is fevers, chills, headache, etc. But the rash is most very common in erythema migrans, and the rash looks as you can see in this picture. We're not talking about this or the size of it, but you can come back and look at this. Again, this is from CDC, and this is what early signs of Lyme disease show. Later signs and symptoms, days to months after the tick bite, significantly are the severe headaches, additional rashes that are in other areas of the body. Patients have been known to get facial palsy. They have a Lyme carditis on occasions, and they do get episodes of dizziness or shortness of breath. There's many other symptoms, as you can see, but these are the most significant ones. The Lyme disease, as you probably know, is a clinical diagnosis. You have to get a very good medical history, you have to see the symptoms, and you have to know if there's been exposure to the ticks. The clinical manifestations are stage 1, acute localized disease. Stage 2 is subacute disseminated disease, and stage 3 is chronic or late persistent infection. Diagnostic tests for Lyme, as a lab director, I've been told for years by CAP and by CLIA that these tests are very insensitive. Therefore, a negative test result doesn't mean Lyme disease is not present. There are many reasons why someone can actually have Lyme, but they have a negative test result. And this may be that there has not been time for antibodies to develop, or the immune system may be suppressed, or the person may be infected with a strain of spirochete that the test doesn't measure. Chronic Lyme disease is what most of the patients come to the doctors that we work with and are seen for various reasons. If they're not diagnosed and treated early, the spirochetes are known to spread and go into, quote, hiding in different parts of the body. It takes weeks or months or even years later that the patients can develop problems within the brain and the nervous system. Muscles and joints, heart and circulation, digestion, reproductive, any of these systems, they can go hide in them. But the symptoms may disappear even without treatment, and different symptoms can appear at different times. So there's something that we see a lot of, or we hear a lot about post-treatment Lyme disease, and it's either untreated or undertreated Lyme, and that can cause some people to develop severe symptoms that are very hard to resolve. This condition can be referred to as post-treatment Lyme disease, or PTLD, or chronic Lyme disease, CLD. We don't know exactly how many people who are diagnosed and treated remain ill. It's estimated that 300,000 a year are seen in the United States for, quote, Lyme disease, end quote. And it's also estimated that it ranges from 10 to 20% of those that are diagnosed don't improve. A recent study of early Lyme, well, that's not a recent study, but a study that CDC cites, and also the different sites on the websites about Lyme say that Ockett in 2013 showed that the EM rash was reported early and 36% remained ill even after some kind of treatment. There's a chronic late persistent Lyme that follows latent periods of several months to a year after initial infection. 60 to 80% of these patients have musculoskeletal complaints, and most common are arthritis of the knee, and they can also be in the ankle, elbow, hip, or shoulder. The neurologic impairments are many, and memory loss is one that we get a lot of from patients. I think I have fog, but I don't know if it's due to the mold, or is it due to the mycotoxins, or is it due to the Lyme disease? And also, I'm very, very tired. Do I have thyroid problems? Do I have endocrine problems, or do I have Lyme disease? So CDC talks about a two-tiered testing for Lyme disease, which may or may not be done by a lot of people in the US, but the two tests available are the EIA, or enzyme immune assay, or the immunofluorescent assay. Now, this again is out of CDC. So if either one of those two tests are positive or equivocal, then you have to go back as a clinician and decide when were the symptoms and signs. Were they less than 30 days? If they are, I need to do an IgM and an IgG Western blot. If they're greater than 30 days, the only thing that will help is an IgG Western blot in most cases. And that is because IgM is early antibody for early infection, and IgG is for chronic infections. If the EIA and the IFA test are negative, then it's considered a alternate diagnosis, or if the patients are signs and symptoms consistent with Lyme, then you should get another serum and test further. There's a Western blot test that is being done, and again, this is not something that is easy to read for most labs. That is difficult to see these lines, and patients will say, well, I have 6 out of 10 lines, or I have 3 out of 6 lines that are positive, and my doctor said that this is equivocal, or maybe I have it and it just isn't showing up. Well, the false positive Western blots can occur due to infections, even in Epstein-Barr, and they can occur in mycotoxicosis, they can occur in other diseases. Dr. Neil Nathan has written books and papers about these since 2012 to 2014, and he now has a book out, and he will be presenting next month in Denver on mold and mycotoxins, and he often thinks that these are overlooked factors in chronic Lyme disease. We have heard through various discussions with other doctors as well as with patients that once they get rid of or decrease the number of mycotoxins in the patient, the Western blot tests go away, or the lines are difficult to read. The concurrent infections that occur in the peer-reviewed literature are babesiosis, ehrlichiosis, and mold and mycotoxins. Of course, there are others that I mentioned in previous slides. There's only one laboratory test that I'm familiar with that FDA has given approval for, and that's from IGeneX. This is an immuno blot test that is available, and the CDC believes that this is very helpful if it's positive. I need feedback from other clinicians as to whether or not that's helpful, but I also know that the immunoblot test becomes negative if the mycotoxin tests are decreased to 0. Again, this is the picture from last time that I gave you on mTOR. That's the mammalian target of rapamycin, and it coordinates all the cell growth throughout all the cell components, and it associates itself with growth factors and nutrients and energy status of the cell. Consequently, it increases energy production, but when it does that, it creates all this junk products that need to be cleared. So we have this thing called autophagy that gets rid of all the junk. It's like the garbage man of the cell. It contributes to clearing the cells of all this oxidized material that we see in the body. And these consist of proteins and DNA and lipids. However, this autophagy is definitely most active when mTOR is low or decreased. And you'll notice here NRF2 and KEAP1 proteins, which I think are kind of neat proteins to discuss. NRF2, if you can't remember anything else, remember the Nerf football that we had when we were kids, but NRF2 regulates mTOR. So if mTOR is decreased, then autophagy is increased. So there's an inversely proportional relationship between mTOR and autophagy. Then you'll notice down here in the very bottom, I have SNPs that may aggravate getting rid of all these products, or they may interfere with any of these products that are going on in the body in nutrition. So the bottom line here of this whole seminar or webinar today is to say, if we get Lyme disease or if we get any kind of environmental problem, it affects mTOR, and inversely, it will affect autophagy. And if that occurs, then we can't get rid of the different end products of any of these infections. So again, we talked about treatment. It's variable. We're not going to discuss it in the webinar except for this next slide. This shows what early Lyme disease is being treated with in a lot of clinical facilities, either doxycycline, amoxicillin, or cefuroxime. However, that isn't the case in most issues in chronic disease. The patient's condition in the body may allow the invading spirochete to thrive, or the conditions may weaken the immune system, which decreases the success of medical treatment. So, nutrient genetic research has been done for a number of years that are conducted by the Nutrigenic Research Institute, conducted and led by Robert Miller, who's a naturopath who is very, very famous, to me anyway, and very, very knowledgeable in the issues of biochemistry. And he's investigated nutrition and detoxification therapies to support the health in Lyme disease patients. There are genetic patterns that he's noticed in Lyme that have led to production of peroxy nitrate. Peroxy nitrate is the center of most of these cases. It's an oxidizing agent that damages the body. It adds to toxic load. It depletes glutathione. So if you've had mycotoxin treatment and they say to give you glutathione, peroxy nitrate is going to get rid of the glutathione, and it weakens the immune system. Peroxy nitrate also allows patients to remain chronically ill, even though the best antibiotic is given. So if we can't determine if peroxy nitrate is there, then we can't get this patient better. The oxidative stress rates in chronic Lyme disease patients are increased due to mitochondrial dysfunction. So if it's well known that mitochondria are affected by the different infections, such as bacterial, fungal, and now we're talking about Lyme disease. It also is lowering the ability to detoxify in the human body, and it increases iron oxidation. So we have increased iron storage in the patients. Again, INGA is the Integrative Nutritional Genetic Assay. We give it saliva so we, so to speak, spit in a tube, and it's conducted to evaluate the presence of these genetic mutations called SNPs, which are single nucleotide polymorphisms. These SNPs reduce the production of such needed molecules. So if you get a SNP and you need some kind of end product in your biochemistry pathway, you're not going to have the needed molecules to perform critical functions in your body. So you're going to interfere with all these toxic substances that are oxidizing agents that are interfering with your nutritional status. So where are the SNPs that are creating the deficiencies? Well, they're in the mitochondria. They affect methylation. They affect detox. They increase glutamate. And if you increase glutamate, you increase peroxy nitrate. It also increases ammonia, and we have higher absorption of iron, and it impairs DNA production. In other words, if you get an infection such as a mold that affects mTOR, or you get an infection that is associated with Lyme disease, you can affect one or all of these areas. And all of these areas cause decreased energy, decreased ATP, increased oxidation, and increase in a lot of problems with storage of toxic substances like ammonia. If we store ammonia, that's really detrimental to the cells. Of interest, though, if you have high absorption of iron like hemochromatosis, you will see also a problem with increased treatment and increased efficiency of improvement. So we're going to take just 4 of these areas. The mitochondrial function. If the SNPs, these are the variants, are present, we get decreased ATP. Well, that makes sense because mitochondria make ATP. And so we get lower energy in our body and we feel lethargic and we just can't function. It also increases glutamate, which I talked about, which increases peroxy nitrate, which is like a poison to the rest of the cell, and it's oxidizing everything. So you don't want increased peroxy nitrate, because if it does, you're going to stop all functions. If you look at the methylation pathways, that's very important as well. Methylation is associated with folic acid being transformed into methylfolate. And if you remember from your biochemistry, this is an essential pathway. And the Lyme patients have more SNPs in this area in methylation, and that stops this reaction with folic acid being transformed into methylfolate. So we want to not only look at the mitochondria, but we want to look at, are the methylation pathways affected by these SNPs or these variants? There's another area, detox or detoxification. There are certain genes that are associated with different phases of liver detoxification. There's a phase 1 liver detox and there's a phase 2 liver detox, and these are discussed in great detail. But when patients call me, they say, we can't get rid of certain drugs. And when we look at their CYP gene in the INGA test, we see that the CYP genes are increased, and these are associated with cytochrome P450 enzymes, and therefore drug metabolism can't occur. Glutathione is also associated with phase 2 liver detox. And so if you have increase in the SNPs, then you're going to decrease your use of glutathione. Now, there's one other one that I heard about when I was in the military a little bit, and I heard a lot about after I got out of the military, and that was with Agent Orange and with other pesticides. Patients who have a SNP in this area of PON1 enzyme development. PON1 is the gene that controls the enzymes to detoxify pesticides and other toxic agents in the environment. If PON1 is decreased, you can't detoxify. So we have other issues that the we've seen this in some of the Lyme disease patients, that the CYP genes, the glutathione genes, and PON1 are affected by the Lyme disease. And lastly, there's excess ammonia. And if you look at the urea cycle pathway, that's associated with increased ammonia. And the genes here that are affected are CPS1 and ASS1. So when we look at the assessments coming out of Rutgers University to help us evaluate all this, we look at all these genes and if there are variants in them, and then we can tell the client or the doctor if there's supplements that you can bypass a lot of these the gene pathways. So Dr. Miller has done a number of SNP studies on these variants, and it's very exciting. It's amazing how much he knows and in these pathways. And he's talked about phase 1, phase 2, phase 3 SNP studies, especially when it comes to Lyme disease. Now, if I was going to go through every one of those SNPs, if we haven't already put you to sleep or you left because it was too complicated or we couldn't get to you because of some of these problems we're having, you will leave when I start talking about all these phase 1, phase 2 SNPs. So what I'm going to do is distill them down by looking at Dr. Miller's issues and his discussions, and then write a white paper for you to pull on from us. We'll make sure that Dr. Miller agrees with us before we put that white paper out. So if there's any questions now or otherwise in the future, feel free to contact us at this website, these different websites or these different pathways, as well as email me at that email. So let me re-summarize everything that I've just said. Lyme disease, I want you to take away certain things from here. Lyme disease is a spirochete, and it's associated with these ticks in different parts of the United States. They come in, they bite you, and you get an early diagnosis. The docs can sometimes find out if you definitely have it, if you have an antibody, an IgM antibody, or a possible IgG, which is later on disease. But at the bottom line, sometimes there's nothing because it's too early or it's in a chronic stage that is hidden. These organisms, once they get in the body and they're not treated early, they can go hide in the body and do their oxidation destruction within the body. So once they get in the body, the docs will give you different antibiotics, knocking on wood that maybe this is being caught early. Well, you start feeling better. Okay, then you say, oh, good. But then you find out that you're not feeling better. And now you have this chronic disease. Then you either start hating the doctor or you say, I got to find another doctor to tell me. Well, the other doctor looks at everything. He doesn't know what to say. You go back to the old doctor. He doesn't know what to say. Well, let's try a different antibiotic. Well, I've talked with patients for years that have gone on different antibiotics and nothing. They can't get better. And so then they say, well, maybe it's the mold. Maybe the mold is causing this problem. So they do a test through our lab called the Mycotoxin Test. And we find the mycotoxins. Oh, that's the secret of this. I found the secret to my life being miserable. And so you try and get rid of the toxins. Well, if you talk with mycotoxin treatment docs, they'll say, well, we want to give glutathione, or we want to give clay, or we want to give something to get rid of these, absorb them in the gut. You don't know whether they came in through the inhalation pathway or the intestinal pathway. So you give all these different things. The patients hate glutathione for a number of reasons, but the number one reason is I feel sick. I'm not going to take it. So they don't take it. They're non-compliant. Then they say, well, now what am I going to do if I can't give them glutathione? Well, then it's really guessing. I'm sorry, but I think When I talk with docs and when I talk with patients, they say, well, we're going to try this, we're going to try that. And that's commendable that everybody wants to think about, well, we're got to try something to help these patients out. But as you can see, and I've talked about this in earlier webinars, that you need to be your own patient advocate. You need to know what is personalized medicine. And this thing of Dr. Miller's that he's doing is becoming personalized medicine. It is personalized medicine. You're going to give him something to evaluate through a university. They're going to do 1,800 different SNPs or variants of genes that cause all these problems in your nutrition. Because if you can't feel better because of your toxins being present, then what are they doing to you? Are they causing you nutritional problems, or are they actually causing you destruction of cells? Well, if you look at what peroxy nitrate does, it causes oxidation. Well, when you look at peroxy nitrate and you look at all its effects on different things of glutathione, etc., they all tie together, and mTOR is the center of that. That's why Dr. Miller has put mTOR into the center. And mTOR is affecting those SNPs. The SNPs are affecting mTOR, and they all they're just overseeing each other's activities. So we really have to understand what the genetic makeup of our nutritional status is. Keep in mind, INGA is not a genetic analysis. We don't do parental testing. We don't do all these other things that you would want to know for diagnosis of a tumor or something. But we're looking at your nutrition on how you can build up your nutrition so that you can fight these toxins. They're not so super smart. You're smarter than them, but you have to be smart enough to know where I can deal with getting rid of them. And you can't be guessing. Now, I'm not saying all doctors guess, but we haven't had something like this of Dr. Miller's or other nutritional tests for forever. And now they're coming into their own life, so to speak. So if I was going to take anything away from this webinar, I would say be your own advocate, know what Lyme disease is, know what mycotoxins do. Don't just say, I have mycotoxins, I got to get rid of them, because you can't. You have to look at all, you got to make yourself stronger in your nutrition, because the docs can give you stuff to get rid of them. But if I've heard this talk about, oh, we got to destroy the house, we got to destroy everything, and you got to go away from this. Well, then you become, quote, the bubble boy or the bubble girl that they showed in Seinfeld. And that's not possible without you going absolutely nuts. So you have to treat what, you got to make yourself stronger. And that's what the nutritional analysis does. So I'll get off my soapbox now and see if there's any questions. If not, we can close off for the day, and we'll see what you can send us by email. I appreciate the time that you've taken to listen, and we'll stop now and talk to you next time.